Well, thanks very much for the invitation to speak. These are my disclosures. I could summarize this talk by saying that artificial intelligence is already changing the way we look after patients, and it will revolutionize the care of them in the near future. So traditionally, our pathway has been someone with chest pain, we do some kind of stress test often, we put them on some tablets, they always used to end up getting an invasive coronary angiogram, and with or without the help of a multidisciplinary team, we would then choose a revascularization option for them. CTCA and artificial intelligence has already disrupted this traditional pathway. It certainly has taken out this pathway to a great extent. In the UK, nearly 10 years ago, NICE recommended to doctors that patients with new chest pain had a CTCA as their upfront test in 90% of cases, and thereby recommended getting rid of stress testing in most of those patients. Now, this was greeted by a mixture of alarm and disappointment by a lot of frontline cardiologists, but in fact, in the latest guidelines from the ESC, as you know, this is now a 1A recommendation for the majority of patients, so that's how far CTCA has already come. But AI is driving this revolution in the use of CTCA up front. So there's now a burgeoning literature that suggests that the accuracy of artificial intelligence-guided CTCA reporting is now very, very good. And it speaks to the prospect for an automated, accurate, and probably human-free CTCA reporting for your patients in the very near future. Now, knowing about atheroma on a CT is great, but we often, especially interventionists, need to know how to target ischemic people and ischemic vessels, and FFRCT gives us an almost unique ability to do that non-invasively. The facility to diagnose a narrowing allows us to apply disease-modifying medical therapy, but of course, if we're going to consider stenting, we want to be able to target ischemic lesions. And the data from FFRCT studies, both observational in red and the 2 randomized trials in blue, show a consistent benefit in terms of reducing the rate of invasive angiography we need to do in a cost-neutral manner, with a faster patient care pathway, and with no increase in event rates despite fewer invasive angiograms. And the portfolio from the FFRCT HeartFlow offering is now driven by artificial intelligence in order to speed up the process, allow us to see where there is atheroma, how severe it is, whether it's flow limiting, and in particular to analyze the plaque in order to do some kind of analysis about risk, which we'll come back to in a second. The other part of the pathway that the CTCA and artificial intelligence is already disrupting is our decision-making in terms of revascularization. Patrick Sorois and his group has now published 2 studies that suggest that a heart team using CTCA with FFRCT can decide almost as well as with invasive angiography which patients need bypass surgery. Furthermore, HeartFlow is shortly going to be relaunching a planner tool which allows you to model what would happen if you stented lesions by rendering the vessel free of that stenosis in order to see how much stent you would need to put in to see if you can render the vessel ischemia free. And that can be done on the FFRCT CTCA output, and so it can be done in patients when they've never been to a cath lab. It's been validated, the planner tool, on invasive lesions of all different types. It's been validated against post-PCI pressure wire and against post-PCI OCT, minimal stent area, and the correlation is very good. In this very elegant study, a comparison of the management of patients by a consensus group of physicians based on their interpretation of invasive angiography compared to when they're given the access to FFRCT and the planner tool suggests that it has a huge effect on patient management in nearly half of the cases, but also on lesion-specific management, and it affects management in all different directions. So this raises the prospect that the planner tool could be used for decision-making, not just about PCI, but about which patients need which type of treatment modality. Again, it takes away the gatekeeping function of the interventionist who traditionally has made these decisions and potentially gives it back to the heart team so that they can decide with the help of the planner tool which patients will benefit from PCI and which need other types of treatment. And of course, that can theoretically all be done before the patient's ever been in a catheter lab. So perhaps a novel pathway will be that patients with stable chest pain have a CTC up front. If they don't have coronary disease, then they will be reassured in some way or other, allowing for INOCA. If they have coronary disease and it's not a critical left main, they'll be treated with tablets. If they have ongoing angina, the FFRCT can then tell us whether they have ischemia. And currently, they will tend to go to a lab and then have a revascularization option. But this speaks of in the future that the FFRCT will be used increasingly to decide which of them needs bypass surgery. And when they go to the lab for PCI, what kind of PCI they need before they ever get into the lab. This is just a start. In the future, artificial intelligence with this type of CTCA technology will change the way that we treat people even further. Let's start with the heart team. We take account a whole load of patient-specific and lesion-specific factors when deciding which is the best treatment modality. And in fact, the heart team now, on both sides of the Atlantic, has a Class 1 recommendation for difficult decision-making. And we all know this is completely unrealistic in a variety of situations. What happens if you don't have access to a heart team when you need it? If you work in a small centre, if the heart team meeting was yesterday and you've got a decision to make today, and if you have that strange situation where one of the surgeons, for example, is a certain type and he hasn't got anyone else from the surgical specialty with him. Now, there are a lot of different people's opinions that make up a heart team decision. And in each of those cases, those people are subject to various different types of bias or educational bias that can affect their decision-making. But it's entirely plausible that using deep learning models that take account of all these factors from thousands and thousands of cases, that we can come up with a heart team app that gives you the same heart team consensus opinion without ever needing an actual heart team in place. And bearing in mind what I've told you already, that means that in a large proportion, you can get a heart team opinion for a patient with chest pain before they've ever had an invasive angiogram from the CTCA and the FFRCT offering. The other thing that will change in the future, I think, is which patients we focus on. At the moment, we're focusing on patients who are symptomatic. But there's going to be a revolution. You must be the change you wish to see in the world. We are going to change to seeking out high-risk patients, high-risk vessels, and high-risk lesions before they ever cause symptoms, and particularly before they ever cause an event. This is already becoming a reality. This is the Emerald 2 study that was published earlier this year. It took adverse plaque characteristics, adverse hemodynamic characteristics from FFRCT, plus a whole load of clinical characteristics, put it together in a deep learning hierarchical model, and came up with an enhanced way of identifying which lesions are likely to have an event in the future over a time-specific period and which lesions are not. This has also been done with the fat attenuation index type assessment of coronaries, also using a deep learning model. So we are going to be able to identify high-risk lesions. This is mind-blowing. Imagine what this means if you can identify high-risk lesions in individuals to primary prevention. Imagine the situation where patients who are presenting to their doctor who have risk factors and are being considered for statin therapy for the whole of the rest of their life could have a CTCA with FFRCT and plaque analysis, and in association with all their clinical factors, could have a hierarchical risk assessment, not just of their individual risk, their vessel's individual risk, but their lesion's individual risk, to say which of them are going to have an MI and which of them are going to die of an MI. This is absolutely plausible in the future using deep learning artificial intelligence, and it would change the whole paradigm in the way that we focus healthcare delivery. But artificial intelligence will never be a match for natural stupidity. Thank you very much.